Okay, great. Well, welcome and thank you everybody for being part of this. We're really excited to host this virtual panel on COVID-19 and the momentum for better maternal health care. My name is Neil Shah. I am the director of the Delivery Decisions Initiative at Ariadne Labs, and I'm also the co-chair of the Obstetric COVID Innovation Collaborative. And well, it's December 3rd, 2020. And at this moment, our country is facing an economic recession and a public health emergency. And these are both things that really underscore the urgency of making substantive changes in the way that we deliver healthcare in our country. And at the same time, paradoxically, there are two things that in some ways make it harder to do those very things. A recession is not just about access to capital, it's equally about really a mindset in which we realize that the ways that we used to spend money aren't getting us the results that we want. That's fundamentally what a recession is, and that's what we're living through right now. And our goal, given that that is the case, is to provide some guidance on how we can and should and need to be spending money differently to get the results that we do want to see. And so what that means is we're going to be speaking in terms of economics and marketplaces, but we're also going to be talking in terms of justice and equity and trying to hold all those perspectives together in order to make sure that everyone who's a part of this, whether you're a clinician or you're part of a foundation that makes investments, or you're a health system leader, whether you're in a position to make the investments yourself or you're in the position to advocate for these investments, that we can actually translate some of the findings of this work into impact. So let's go ahead and go to the next slide. And the agenda for today is I'm going to briefly introduce our panelists. We'll talk a little bit about how we got here, and then I'll turn it over to the panel to have a discussion about what it was like to give birth during the pandemic, what it has been like to care for people during the pandemic, and what that really means about where we need to be going. And then, of course, at the very end, we'll have a little bit of time for questions from the audience, and we'll reserve 1 or 2 minutes at the very, very end for you all to fill out a quick survey for us that'll guide our next steps in this process. So let's go to the next slide. We're very, very lucky to have this outstanding panel. Our moderator today is Heather Young, who with me was the co-chair of the collaborative this summer. She's also a professor and the Dean Emerita at the Betty Irene Moore School of Nursing, and the National Director of the Nursing Fellowship, the Moore Nursing Fellowship, and she'll be the moderator today. We also have Betty Janey with us, who is a wife and a mother of 2 boys. She's a person who gave birth herself during the pandemic and also brings a professional lens from having a background in social work and healthcare improvement and working in virtual production support right now. Our other panelist is Rose Horton, who is the executive director of the Emory Decatur Hospital. She's also a national nursing leader on many fronts. And finally, we have Dr. Judette Lewis, who is currently the president of the Society for Maternal Fetal Medicine and the chair of the Department of OBGYN at the University of South Florida. So we'll go to the next slide. And thank you to all our panelists for being part of this. And thank you to all of the partnering organizations and funders who've made this possible. There are a dozen organizations represented on this slide, which include everything from academic institutions to think tanks, to professional organizations, to foundations. And I think one of the things that I think is really powerful about the work that we've done together, which includes many of the people who are participating now in the middle of your workday, in the middle of your week, is that this really was a collective effort from so many people. And just really grateful for that. So let's go ahead and go to the next slide. Now, our core audience for this includes a lot of people for whom childbirth isn't their primary occupation, professionally or otherwise. And so I think it is important to just ground a little bit in why childbirth. For many of certainly for our panelists and for a lot of you who are participating, the answer to this might be obvious, but people who are giving birth are very much a bellwether for society as a whole. So if our moms are unwell, society is unwell. And for that reason, pretty much every injustice in our society shows up in the well-being of mothers. And that is why childbirth. We see maternal health and the maternity care system is very much a leading indicator for what's happening with society generally. And that's part of our motivation for encouraging everybody to focus their attention on maternal health, even though historically, this isn't an area of healthcare that has gotten the attention that it needs. And this framing comes directly from a National Academies report that came out in January 2020, really right in front of the pandemic and everything that ended up motivating this report. And fundamentally what it highlights is a mismatch between the care and support that people are getting and what they're expecting and what they actually deserve. So let's go to the next slide. And again, our goal is to really provide guidance to people who are in positions to make material investments and improvements. And we want to do that by reflecting how the COVID-19 pandemic has really caused a lot of the dynamics to shift. It's counterintuitive, but in many ways, even though we're in a recession, we believe this is the ideal time to be making important investments because demand for change has gone up in ways that are much clearer, and actually some of the supply side forces have changed as well. Let's go to the next slide. The way that we did this was by working very hard to make sure that we're inclusive of as many voices as possible. We aim to do that by being clear about our goals and our values and being specific about what we mean by inclusivity, and ultimately trying to make the spaces in which people were sharing very difficult things about what happened to them over the course of the last few months in the pandemic were safe spaces for sharing. So let's go to the next slide. Over the summer, over 4 sessions, we convened about 250 people from across the country to offer perspectives on what they were seeing. And with each session, we made adjustments along the way to make sure that we were inclusive of people who had given birth, people from more rural communities. And we focused the first 2 sessions on trying to outline the shared challenges that everybody was dealing with, and the last 2 sessions on really trying to surface the approaches to trying to solve them that we thought were the most promising. So let's go to the next slide. And it's just to really highlight where this work was situated in the context of the broader pandemic that we were seeing. So we felt compelled to do something based on what we were seeing in April and May. That first wave of the pandemic, it looks smaller than what we're experiencing now, but what's really important to recognize is that it was primarily felt by a handful of cities: New York, Boston, Seattle, San Francisco. And in those cities, back in April and May, we were seeing what much of the country is seeing now, which is that we were so overwhelmed as a health system that our beds were full. We had to shut down elective procedures. And we really had to think hard about how to use our limited capacity to keep people safe. Then during the summer, a lot of those sort of coastal cities that we had an opportunity to learn from had a little bit of a decrease in their case rates. We were able to reopen a lot of services, but the middle of the country started to experience more challenges. And that was exactly when we were convening people. And as we speak now, we are on the ascent of a fairly ferocious 3rd wave that is likely to get worse over the course of the winter before it gets better again. And we really see this as being a timely panel to hopefully offer some guidance for some just-in-time investments and changes that people can make that would make a big difference. So let's go to the next slide. Everything that we're going to share today is based on a white paper that I'm sure many of you are aware of through the registration process for this, but we can also drop the link again in the chat. And there's an executive summary. There's also a fuller white paper, and it's not meant to be read linearly. It's actually meant to be navigated a little bit as a choose your own adventure to make sure that the findings that are in it can be used in ways that are most helpful to you based on your local needs and based on your local context. But there are a couple of sort of core recommendations that are in it that cross-cut. So let's go to the next slide. The first is that amid the many, many things that seem urgent is to focus. We had our participants over the first 2 sessions outline all of the challenges that they saw. And then we generated literally thousands of ideas that we then put together and synthesized and had people vote and rank the challenges that seemed the most cross-cutting and the most salient. And they fell into these 3 categories. We already knew before the pandemic that our health system was challenged in terms of coordination and continuity, but boy, did it get disrupted, especially for birthing people, especially when it came to prenatal care, but even honestly on the inpatient side and afterwards. And so that was a challenge that was at the fore of many people's minds. The other was access to family and support, which is true across healthcare delivery. But in childbirth, is sort of uniquely evidence-based as one of the most important ways of improving outcomes. And as we all experience varying degrees of isolation over the last couple months, we saw this in our hospitals and health systems as well in ways that were uniquely challenging. And finally, we heard a lot about ways that provider-patient relationships were strained, both due to founded historical reasons for mistrust between oppressed and marginalized communities and health systems, and also just because there's so much shifting information and a real challenge around communication. So strengthening patient-provider relationships came to the fore as well. So recommendation 1 is to focus on these 3 things. Let's go to the next slide. Recommendation 2 was to try to really highlight the core set of innovations that seem to address those 3 things. In many cases, all 3 at once. So they included things like accessing virtual care, and not just in terms of like adopting a platform, but really trying to think through how and why. Interestingly, building trust emerged as an independent innovation category. And I think it's actually quite powerful to think about that as not something that we take for granted, but an explicit goal and what that really means about practice and process. There's an innovation category around customizing needs, knowing that needs vary, around coordinating services, around adapting roles as we saw people get redeployed, and utilizing alternate care settings. And then finally, we go to our next slide. Our third recommendation is to accelerate what we're calling momentum. Through exploring these innovations, we surfaced a number of ways in which these supply and demand dynamics have shifted. To create more capacity in the system, we had to change the way we paid for care. Accessing virtual care became more possible because telehealth got paid for at parity. It became more possible to adapt roles because we were able to recruit nurses and physicians from across state lines, even if they had limited licenses. And all of those things were very, very helpful. And so a number of our recommendations are really aimed at augmenting or accelerating the momentum that already exists. So let's go to the next slide. And, I think some of these market terms have very precise definitions, but generally speaking, what we're talking about is taking the desire to make things happen, which is much more acutely felt at this moment than before the pandemic, and some of the enabling factors, and trying to really push them to make sure that we're getting to a place in the weeks and months ahead that we're making impactful investments. So with that background, I'm now going to turn it over to Dr. Young to moderate the panel.
Thank you, Neil. Today, I would like to thank you all so much for being here. I'm delighted to be with our fine panelists today, Betty Janey, Rose Horton, and Judette Lewis. We really appreciate all of your involvement throughout this process and your contributions to this important work. And I'd like to get started with a question that I'd like to pose to all of you. And I'll start with Judette, if you wouldn't mind kicking us off. The question is, in a few words, what's been the most important insight you gained through the conversations we've had about maternal care?
What was really surprising and reassuring was that there were very consistent themes across different centers, regardless of differences in patient population. And so I think there was so much that we could learn from others. And for me, that was an important takeaway point because in this pandemic, as you're caring for patients, sometimes it can feel very isolated.
Mm-hmm. Thank you. Rose, what do you think?
So I echo everything that Judette said. There were a lot of themes. I think for me, it really spoke to the need for us to reach out to the community, because I do believe that the answer to everything that we need as it relates to caring for our community exists in the community. So the ability to partner and to hear many different voices, I think that was a really great theme that was fairly impactful to me in this work.
Thank you. And Betty, what about you? What struck you, and what was your most important insight?
I think just similarly, working with the community to bring together resources to support families that are in this period in their life, and then also building up trust, because a person can't trust you in their most vulnerable time, or the person should be able to trust you in their most vulnerable time in order for you to help them. And so just, I appreciated seeing that trust was elevated as one of the themes as well.
And speaking of that, you had a somewhat unique experience of giving birth during the pandemic. Mm-hmm. And that must have been incredibly challenging for you. And we'd love to hear a little bit about your experience and what particularly made it difficult to be having, what could have helped you while you were going through it?
Yes. So I gave birth in April, April 6th. He was actually 3 weeks early. So that in itself was a very big surprise. And everything was unexpected. We tried to plan for the birth as one would do. We had planned for my mom to come stay with us to help take care. I have a 3-year-old son as well. And she was actually in Ghana at the time, staying in one of our houses. And she ended up being stuck in Ghana until she actually just came back this past September. And so she was unable to come join us to help. And so just trying to scramble for help and support, not only for myself in this new birth, but also with a 3-year-old and then my husband working full time. It was such a challenge. The day of giving birth, I'd gone in for a regular NST testing because I was high-risk pregnancy. So I'd gone in for regular testing and was told that the baby was stressed out and that they needed to deliver him today. And I went in about 2 p.m. and, didn't actually have my C-section until about 11 in the evening. And so there was just hours and hours of sitting by myself, not having, anyone to talk to, no questions answered, trying to communicate with my husband, but, he has all of these questions and I didn't have the answers. And, on top of all of the challenges of not really being able to see people's faces. And so it was quite a unique experience, but the end result was a beautiful, healthy baby boy. And so I'm just thankful for that.
Yes, I'm thankful for that too. What do you think could have made a difference, Betty? I mean, it sounds like an incredible time of turmoil for you and for your family. And what could have been different? And out of this report, we've discovered what would you like to have seen happen the most?
Yeah, I mean, I'm a planner, and so I think just being able to have a plan in place, a contingency plan, some sort of backup that, worst case scenario, this is what we can these are the resources we can pull in. One of the questions that I was always asked throughout both of my boys' births is, do you have care? Do you have someone to help, when you go home? And I always would say yes, but what if I had said no? And the reality was the type of care that we needed, the answer was no. And so working with whoever is part of your provider team to really understand the care that you need and how to get access to the care that you need, the resources that are available, and just having that plan in place would have alleviated a lot of the stress that we experienced. Having answers, I know at the time it was very early in all of the medical system. And so everybody didn't have all the answers, but just some answers. And I was given answers when they were available, but it just seemed like a lot of sitting and not knowing and waiting. So just having some answers, being able to feel like I have a plan, some sense of control, some sense of normalcy within all of the craziness.
So what
Yeah.
Betty's, excuse me, I'm sorry. So what Betty's speaking to, again, is that we didn't anticipate a pandemic, right? So this is our first exposure to a pandemic and to work as usual during the pandemic. And I remember one of the early conversations we had in our system was around permitting or allowing a care partner to be part of the birth experience. You know, we're accustomed to the entire family as much as our patient or clients want during the birthing process. And I remember when we had the conversation, because some of the hospitals across the nation said, no, we're going to lock it down and we're not going to have any care partners, you know, any family for birth. And when we had that conversation, and I got really emotional and passionate about it, I'm like, we cannot dehumanize care. We cannot cause our clients to suffer and to be traumatized because we're in a pandemic. It is our responsibility to permit at least one person to be there with them. Because all I can imagine is if it was me and I'm in labor, I'm already scared to death. It's a pandemic, right? People are coming to the hospital because they're sick and they're dying in the hospital. So I'm coming to a place that's not safe, and you want me to come without my person? So we had a really robust conversation, and we did agree that at a minimum, one person needed to be there. And it speaks exactly to what you're saying, Betty. Imagine if you were going through all that and you didn't have your husband with you, your person, that you already had that protracted waiting. So that was one decision I think that was really important. And I'm glad that most of the country did move to saying, hey, care partners, families are really important in this decision and they need to be part of it.
Yeah. Judette, going back to that time and in that period when Betty was giving birth, what was going on for you?
You know, I think, you know, as I'm listening to Betty's experience, I can't help but think also that her experience, if she was giving birth now, would be a little bit different. My heart really went out to those centers who were hit very hard early on because the environment was so much harder to navigate in the beginning. They were facing, they couldn't even get COVID tests. And so a lot of the policy decisions that affected childbirth were being made simply because they didn't have, hospitals didn't have resources. And so for a lot of the hospitals, I think some of the decisions now and the policies now, you know, would be more compassionate and more, you know, friendly to the patient who is giving birth. And so, you know, even just the timing of when you encountered this would make a difference.
Yeah, thank you. I'd like to shift gears a little bit and ask you about the idea around one of the themes that was important, which was adapting roles and responsibilities. How have opportunities changed in your experience, in your practice during the pandemic? And are you seeing any particular emerging promising practices around these changing responsibilities, particularly with the lens of equity and justice? Can you address that for me?
Well, I can chime in and say that one of the things that we learned very early on, again, because, you know, the focus was just really trying to figure out, you know, what to do in this public health crisis where none of us were trained for this. And so we were trying to figure it out as we went, that the early solutions did not necessarily have an equitable lens. And so we found certain populations were left behind initially. And if you weren't paying attention to that, then they could be substantially left behind. And so the example for us was telehealth, that we have different centers where we implemented telehealth, and we one responsibility that emerged was one of our physicians took the lead because she had more experience in research in providing prenatal care and working with rural populations. And so she took the lead on telehealth. And so we thought we implemented it well. And then we suddenly realized that one of our centers was using telehealth at a substantially less rate than the other center. And the group that was using it less was the group who could have benefited the most from it because they had more comorbid conditions, but they also had less resources. And so then it emerged that we needed someone to really provide that lens of equity as we're coming up with our policies and our strategies. And that was something that started during the pandemic, but then moving forward will need to continue. So for us, it really provided us with an opportunity to do our day-to-day job better, and may not have emerged without the pandemic.
So one thing that we noticed, to speak to what Judette said as well, is our pivot from an in-person visit or an in-person childbirth education class or inpatient support group to a virtual platform. That's something that we quickly transitioned to, which was really a huge win. And I think one of our first virtual classes, we had 18 couples, and that was really a big number for us. So we're like, wow, this is really great. But as you think about roles and people being redeployed, and how do you use what you have that's available for you, doulas are definitely something that's really incredibly helpful to have that other pair of hands that's really focused on the patient. We had a program that we had put in place prior to COVID, and it's going to come back live in the new year, but it was a partnership that we forged with the School of Nursing to provide labor support volunteers. So we had doulas who were students, and we were very intentional with that because we wanted to be able to develop criteria and utilize the doulas in a way that was, had the greatest impact, that was most meaningful. So some of our criteria was, related to age, if the patient was less than 20, related to, are they alone? That definitely bubbled up to the top. Then they need somebody to be with them. Are they planning for an unmedicated birth? So we were very intentional with that. And as we planned and permitted incrementally to allow students back into the facility in the new year, we'll be able to have that resource of a doula, because we're still down to one care partner, but then we'll have that resource. So I think the benefit of having that in the near future will be really helpful. And even considering using doulas virtually, having somebody that you can FaceTime with and, use your iPad. We use our iPads a lot in the neonatal intensive care unit, but this is another way that we could use doulas to really help and be another support for our patients and our birthing people.
Yeah. So it sounds like some of the barriers we had in the past to these innovations changed. Do you see, where do you see the biggest changes and barriers making innovation more feasible at this point?
I'll go first. Judette and I are looking at each other. So I think it was our ability to quickly react. I think that's one of the biggest things that I saw, because I know within our healthcare system, we've been talking about telehealth, and the percentage of telehealth clients we had, I think, was around 15, 20%. And then magically we were in the 40% because, I love the saying that necessity is the mother of invention. So we needed to do that, and we're able to do that. So I think the barriers were removed out of necessity, and because truly it is a pandemic and we need to react quickly. So that is one thing that I saw that was a good shift. Our community has always been very open and willing to be part of the conversation, so that's not different for us. We had one community check-in, a virtual community check-in with the birthing community, everybody who wanted to be part of the conversation. We have another one scheduled, I think next week, just to check in. So I think that also is helpful to, again, check in with the community, give them space, because we learned a lot when we checked in September. We learned a lot about the increases in home births that were occurring. Would not have known that if we hadn't checked in. Anecdotally, we were reading about different places that were saying that, but to know that that was happening in our community and that our community midwives had to turn people away because the volume was just more than they were able to handle. So again, just partnering with the community to see how we can, which is how I started the conversation. What can we do? What do you need from us? I think that's really always helpful in our process.
Yeah.
So I will.
I'd like to shift.
Oh, sorry.
Go ahead, Judith.
Just one comment. I will agree that, you know, that suddenly we figured out telehealth very quickly, all of a sudden, right? But also part of it was that there was a financial incentive that some of these institutions realized that they were going to just hemorrhage money and not be able to, you know, keep their staffing, and they would have to lay people off. And so I do think that that money also played a role in why they figured it out quickly. And then the other one is government regulations, right? So some of the regulations were lifted that made it a little bit easier to implement. And so I think we just need to keep in mind all of those things that, you know, day to day, you know, plays a role in how successful we are and what we can do.
Mm-hmm. Yeah. So many barriers shifted in this circumstance. I'd like to shift gears a little bit again and go towards the idea of customizing care planning and support. And Judette, I was wondering if you could reflect a little bit about what you've seen in that arena and emerging practices related to that.
I'm sorry, can you repeat the first part?
The question is around customizing care planning and support.
Yes.
And how have opportunities around this changed in your experience and in your practice during the pandemic?
This has been a major area where I think the pandemic has highlighted the need for you know, customizing based on a number of factors, whether it's the risk profile and what kind of services that you offer, you know, the patient who doesn't have any comorbid conditions versus the one who has a high risk condition for the mom or for the fetus, where you may need to tailor the plan for the prenatal care. How you know, how you plan out the proportion that are in-person visits versus telehealth visits, and also making sure they have the resources to do telehealth. You know, whether it's blood pressure cuffs, like that great program that the Preeclampsia Foundation started, where you can get blood pressure cuffs to provide patients who don't have it. You know, so that was a major area that we found ourselves challenged in. But then also, you know, thinking about if you are going to implement telehealth, making sure that the strategy around that is culturally tailored for individuals. One of the things we found was that the one center that didn't have a high uptake in telehealth, as we started investigating some of the patients' perceptions about telehealth, we found that there were, you know, things we needed to explain. You know, there were concerns about privacy, security. There was less access to data plans. And so that if you had a choice between using your data for a telehealth visit versus something else, you may make, you know, certain choices. Or even concerns about, I don't want people to see my house in the background, right? My house is a mess, you know, things that we don't think about. And so, but our patients were thinking about and were providing, you know, a barrier. And so we had to address all of those things, and that the education for the patients up front would have to change. And then our expectations would have to change. So there was a lot, and it was, you know, it's been a continuous learning process for us.
Mm-hmm. On many fronts. Betty, do you have thoughts on this topic of the customizing care planning and support?
I do, but Judette definitely sort of captured a lot of it in her conversation. I think education all around is key, educating the patients on how to receive telehealth, how to ask know what questions to ask, how to show, demonstrate, describe what they're experiencing, because you don't have that in-person interaction that, you can physically say, hey, look, this is what is looking at. This is what it looks like. Just reflecting on my own post C-section telehealth visits with my provider, I was concerned, because you can't really gauge the healing from just seeing it through a phone, a bad quality phone. And so I was really concerned about that. So just educating the patients, and then educating the provider on how to build that intimate relationship, even though they're not in person, because that's, at least for me, that's key. Just establishing that strong bond in that relationship, though you're not in person.
Yeah. And the communication keeps coming up as such an important theme in everything you're saying today, Betty, and the ability to understand, listen, and as well as provide information in a meaningful way. Rose, do you have thoughts you'd like to add to this idea of customizing care planning and support?
I think we may have lost Rose for a moment.
So we've lost Rose, looks like that. Well, I'd like to
if I can just make one more comment, Heather. I think the other thing for us to keep in mind is that now the pandemic is more like a chronic condition, right? And so some of what we observed in the beginning was like an acute disease, and now it feels like, the needs are changing a little bit because it's now a chronic disease. And so we're starting to see a little bit more a change in the expectations of patients, where I feel like in the beginning of the pandemic, everyone was so scared about safety that what they accepted was different. And now I see patients are shifting back to wanting, more of what the birth experience looks like before. Almost as if not that they're less scared, but they may be a little bit less scared because now they just realize we have to live with this, and that, they have COVID fatigue like everyone else. And so some of these experiences that are centered more around being able to be with their families, being able to see their OB provider in person is becoming more important to them. And so I'm almost seeing a little bit of a backlash now.
Interesting. Yeah, this is evolving. The point you made earlier about April is not what it's like now. It keeps changing, and our assumptions keep shifting as we move forward. I'd like to encourage the audience to type in questions into the chat as you like, panelists, and I'm going to ask them a question while you have a chance to do that, but we'll be looking at your questions, and would love to pose some of your thoughts into this conversation as well. I'd like to ask all of you what your thoughts are about innovations that are actually positive, the ones that you see as really positive. How can we sustain them and equity in the outcomes that we're wanting to achieve? And Rose, I'll let you start. I'm so glad you're back. It's fun being in Zoom these days. You never know who's going to be in the room and when they're going to leave. So Rose, would you like to start with the question on sustaining?
Yeah, thanks. And I blame Neil for talking about traffic, and then I got booted out. So I think sustaining, and I love that we're using the phrase momentum, and that, we want to, I think of momentum as pushing forward. I think we need to continue to have everybody focus on the fact that women, birthing people are the bellwether of society, and they really speak to the wellness of society, and that they're important. I do think also that we are pretty clear that during this COVID pandemic that our structural racism is a huge issue within the healthcare system. And it seems like there are more organizations, more people committed to eradicating and mitigating racism. So I think the timing is perfect for us to be able to pull it all together and say, making these changes for birthing people, and especially for the marginalized community, will impact and have a win on all of us. I think the timing is perfect to do that. And this is the last time I'll say it, but again, I think pulling as we sustain, not forgetting the importance of every voice in the conversation. So to make sure that decisions are made in a way that everybody's voice can be heard in our community, and our clients and our patients and the end users are really, really important in that. So I know we're working towards some things within my healthcare system to be really intentional about addressing racism and about addressing implicit bias and how that shows up and how we care for people. So I think that's one thing that will help with our momentum to see some changes within our healthcare system.
Thank you. Betty, what are your thoughts about sustaining innovations and keeping the momentum moving in the way we want it to?
I'd agree with everything Rose said. I feel like the importance is really working with the community and the families and the networks involved in that family's life at that period, and advocating for access through the various resources that are available, and how you can continue to do that, not just in periods of crisis, but throughout, because you need the community always. And just, I think that that's important to just continue that.
Yeah. Judette, what are your thoughts about sustaining and ensuring outcomes?
Yeah, I think sustainability is something that you almost have to, well, yes, you have to be intentional about it. And it has to be part of the equation when you start the innovation or when you devise the innovation. Because already we've seen some attrition of some of the programs we put in place because they weren't sustainable. And so we had to, take a pause and say, okay, let's look at all of the things we're doing, and will we still be able to do this 6 months from now, 2 years from now, et cetera. And I think that's what I would urge everyone to do, is to really look at what you put in place and what will it take for it to just become a routine part of what you do, if it's worth keeping, if it has made a difference. And sometimes it's just minor tweaks to what you're doing that will make it sustainable versus something that completely gets scrapped or becomes such a burden on your healthcare system that you can't continue.
One of the themes that's come up over and over with your conversation has been around trust, around communication, around inclusion, engagement. I'd like to ask you what your thoughts are about how we can look at the culture of healthcare and healthcare delivery differently, how we can promote in our organizations and more of an environment where that's possible. And I'd love to hear your thoughts or examples from your experience about how to move that needle. Because there's the investment of financial, but there's also the investment of the human spirit and coming together around a cause. Rose, would you like to start?
Sure. So one thing that we are doing that I think has worked really well is around education. We did our own assessment and gap analysis about how we're perceived within the Women and Infant Service line. And we saw that there was opportunity for us to address courtesy and respect. So we put a course together on respectful and equitable care. So this is something that we're offering to everyone. Well, we made it mandatory. I say offering like they have a choice. We made it mandatory for everyone to go through respectful and equitable care, because we think that that's how you build trust that everybody who comes through our doors are treated in a respectful and an equitable way. And we started stratifying our data based on race. So we're looking at several of our data. We're looking at C-section rate, we're looking at inductions, we're looking at preterm labor, we're looking at all of that based on race. And we're sharing that data with our providers, and we're sharing it with all of our nurses, because, you know, the data forces us to ask some other questions. So I think as we do that hard work within our organization, it really primes us to be the, you know, the hospital of choice, because people will know that this is important to us when they come through our doors, that they're treated in a way that makes them feel valued, make them feel like they're an important person. So that's one thing that I can speak to.
Thank you. Judette, what are you seeing and thinking about in this area?
You know, there's multiple levels of communication, right? And so the solution differs based on who you're talking about, and it has to be multi-layered. You know, at one point we realized that we have a very diverse population, and so we're trying to communicate with our patients how we're keeping them safe, but all of our communication was in English and on our website, right? So automatically you're missing a group of patients. And so just, again, applying that lens to everything we're doing, and saying, even in the communication with patients, we have to have it in multiple different languages. We have to deliver it in different ways, because people access health information in different ways. You know, and just being very intentional about the communication. And the same thing with communication with our doulas, our midwives, our physicians, et cetera. And that every step of the way you need to have, you know, all of these groups of people at the table, so that you have those voices within that space, so that, you know, the diversity of the voices helps you, you know, create a product that achieves your goal. You know, without all of those people at the table, you can't achieve your goal of sufficient communication. But it is a very key portion of making, you know, helping people to trust the system, you know, whether it's trust the hospital, trust that labor and delivery is doing all that they can. You know, because in the early days of the pandemic, people weren't coming into the hospital if they could help it, because they were scared. And I work at an academic center that is on the news a lot. So they were even more scared, because they were seeing news about my hospital and COVID. And so their perception was, oh, I may get COVID if I go to that hospital. And then they would go to a smaller hospital, not realizing, yeah, but if you have COVID, you want to be at the big hospital that has access to all of the, monoclonal antibodies, or, that don't risk your preemie in a hospital that doesn't have a level 3, level 4 NICU, just because you're trying to avoid COVID. And so there had to be so much communication around that.
Yeah. Betty, I think you dropped off when I asked the question, and I'd like to pose it to you, seeing you brought this up so eloquently. It's around communication, and what can we do to adapt communication and culture change? What are your thoughts about that?
I think you're muted, Betty.
Oh.
You're good now. No, one more time, sorry.
Can you hear me?
Yeah.
Okay. I think it's just important to speak directly to individuals, to look at them in the face whenever you can. If you can't be there in person, the virtual telehealth is key. If you're there in person and you have a mask on, being able to have a picture of yourself, either big or even small, but something that allows the person that's talking to you to see your face to gauge your eyes. I communicate with my eyes, you know, body language. It's critical to building that trust at this very vulnerable point in people's lives. People are bringing you into their families. They're putting their lives in your hands and the lives of their children in your hands. And it's just important to work hard to build that trust. Never take it for granted. Never assume that, you know, you're the medical provider, you know better than the person that's kind of in the situation. And so I think that anything that you can do to improve and continuously strengthen the communication is critical.
Thank you. We have a question from the audience for you that I'd like to pose, which is, this effort that we undertook really focused on the in-hospital experience and the actual birthing time. This question asks, what are some of the thoughts that you might have about models, family-centered models of mental health to support birthing parents, partners, infants, postpartum, and beyond? Based on what we've learned from this, do you have any thoughts about the postpartum period?
I can speak to that, if that's okay.
Thank you.
Yes, so the postpartum period is very important. We have had lots of conversations in our community about the fourth trimester, you know, understanding that at least 40% of morbidity and mortality, well, specifically mortality occurs in the fourth trimester, so 42 days to a year later. So we have had some conversations, and we do understand the need for more robust maternal health just assessment, you know, the consistent use of the Edinburgh, so that we can position our patients and families to be successful and get them connected quickly to a healthcare provider. We think that's a huge opportunity. We're developing right now a webinar to talk about parenting and childbirth during the COVID pandemic. And the goal is to talk about the social isolation that this pandemic has created and the anxiety that it's created, and talking about how to help our community prepare for birth and during this pandemic. So we're really calling out that depression and anxiety and isolation is a real issue right now, and pointing our clients towards solutions or toward care partners who can help them with that. So I think that's one of the most important things that we can do, is to address maternal mental health during the pandemic and especially after birth.
I just wanted to jump in, because I think the fourth trimester, and I like that it's called that, it was such a learning for myself. We were earlier talking about switching in roles. For me, that reflected on how my husband became the primary sort of feeder of our family while I took care of my newborn. And that wouldn't have happened if my mom had come to take care of us. It would have been me feeding the family, and then my mom, and then back to me, and it became my husband. And that changed our whole family dynamic. And so I bring that up because it also reflects on working with the community. Mental health is important, and also sustenance, being able to feed your body, your mind, your spirit. And so working with the community to make sure all of that happens. Who is bringing the family food? Who is taking care of the children? Is there a close person? Because we can't, in the pandemic, you can't just have that large circle of exposure. And so just thinking about that in this fourth trimester is critical. Thank you.
Betty, thanks for focusing on the experience of the person giving birth. That's where we started, and I really appreciate you bringing us back with that very sharp focus. I want to thank you, Betty, Rose, and Judette, for your very thoughtful remarks and for your deep commitment to advancing well-being and health and equity. for birthing people everywhere. Thank you for what you're doing and for all your participation in this process. To our audience, we so appreciate you being here with us today for this important discussion. We hope it sparks questions and ideas for your consideration. In his opening remarks, we embarked on this effort with the goal of making the most of a very unfortunate opportunity, a snippet in time when our usual assumptions have been suspended by the pandemic and the reverberations of the killing of George Floyd and so many other Black people. This period has required rapid response and on so many people, on the part of so many people, to try new ways to meet the many needs of our population. The pandemic also provided a unique opportunity to build on successes and make changes that before were not possible. I was really struck throughout the process by the power of inclusion of multiple perspectives. We grappled with the pressing issues of maternal care during the pandemic, and we were enriched by hearing from so many different backgrounds and perspectives, different roles in the play of maternal care, different backgrounds, geographically and from racial and ethnic backgrounds. We also engaged in conversation with one another to craft solutions. So we listened, we worked about solutions that take into account these perspectives. This is a really powerful tool we can all use as we try to find problems and generate solutions. Having the voices needed to bring a fuller recognition of the issues and the barriers and the opportunities going forward. And as you've heard from our panelists today, this requires a commitment to building trust and listening deeply, setting aside one's own mind. It also requires translation. Neil talked in the beginning about the different languages we talk about issues, whether it's the language of business, of medicine, or of the community. And to effectively communicate about complex issues, we have to think about the stakeholder, the person who's listening to us. So as clinicians, when we talk to health executives, we need to think about the business case. And Eddie so eloquently has said, when we talk with the patients, with their families, we need to think about what matters to them and what information is culturally and linguistically appropriate. So building trust and co-creating solutions is a necessary but not a sufficient step to eliminate systemic racism, geographic inequities, and anti-Blackness in care. I think this work shines a light on a path forward. It identifies beacons along the way. It assists us to prioritize opportunities and make decisions about where to invest our resources. Some of the changes, such as the virtual care delivery, are here to stay at some level. Others might not be sustained when the pandemic abates. And for those that are likely to remain, it's time to invest. It's the right time to make sure that we invest and it's done well. Some of the investment solutions don't carry high financial investment, but focus on culture change. And our panelists have just been talking about the changes in attitudes and the ways we work with each other and communicate that are so vital to advancing health and equity. So we hope that this information will be useful to you, that you will use it, and this conversation, and will spark conversations for you to make a difference, that you can take these discussions up in your organizations, with your peers, with your colleagues, to think about what makes the most sense for you, given your mission, your resources, your priorities. This report is for self-reflection. Where are you now? What's most helpful to you? And this reflection is vital because the heterogeneity of organizations, there's so many ways that we're different from each other that one size does not fit all. And after you've thought about your organization, its capacity, and its priorities, this report can also provide guidance for developing your plan. So we hope you use it, we hope you share it widely, and we also hope that you'll communicate back your experiences and your successes. I want to express deep appreciation to the project team, make the impossible possible in a very short time, particularly Amber, Avery, Monica, and Elizabeth. Thank you for all you've done, and so many others as well. And I'd like to turn back to Neil for the last word. So this work is built on the momentum of change. What is next in your mind for the project, Neil?
Thanks, Heather. It's very hard to follow the wisdom of our moderator or our panelists. I just want to echo all the appreciation. The very next step, hopefully we can put up a slide with a QR code. We're hoping that all of you can take a minute to use your phone, click on the QR code and go to a brief survey. We do think that there's an opportunity to continue to extract lessons from all of this and want to make it as helpful as possible. And your input will be really critical to our ability to do that. And in hearing the panel, I think one thing that I have to just reflect is that my family, part of my family that was in Jackson Heights, Queens, their community hospital was the Elmhurst Hospital in March and April, which was really the epicenter of the global pandemic at one point. It was the place that Judette referred to in saying that back then, there were different circumstances than now. And in many cases, that's true. We have testing ability, we have PPE available, we have better knowledge of how to keep people safe in our care spaces. But our job collectively, as I look across the participant group, people that are in London, people that are in Vancouver, people that are in Tulsa, Oklahoma right now, is to make sure that no other hospital becomes the Elmhurst Hospital going forward. We have that obligation, we have that opportunity, and I'm just really grateful to all of you for coming together and making that the case. So thank you. Please do this survey. We'll also email it out afterwards. And thank you again. Bye, everybody, and be well.
Thank you.